So in this second part, we're going to talk about the peri-implant tissues. The peri-implant tissues are the soft tissues surrounding the dental implant, similar to the way that the soft tissue surrounds the natural teeth. So the implant to epithelial tissue interface, the epithelium adapts to the titanium abutment post, creating a biologic seal. So the biologic seal helps to keep bacteria that are in the sulcus area from going through and destroying the alveolar bone, the bacteria from the oral cavity. The sulcular epithelium surrounds the implant abutment post. So it's creating a similar interface as what you have around the tooth. However, it's significantly different than what is around the tooth. So the implant surface lacks cementum. There's no cementum on it. So therefore, your periodontal ligament fibers and some of your gingival fibers cannot insert into the titanium surface. And so periodontal pathogens can destroy bone faster along the dental implant because of the lack of fibrous support. Then you've got your implant to bone interface. It's called osseointegration. Osseointegration is the direct contact of the bone with the implant. So since there's no periodontal ligament fibers, there's no leeway for movement on a dental implant. There should be no mobility, no inflammation, no pain, and no increased bone loss. What that means when I say no increased bone loss is a dental implant after placement for about the first year will lose a tiny bit of its bone, alveolar bone support. It shouldn't lose more than about 1 millimeter or 2 of bone support, but that usually happens within the first year. Beyond that, periodic radiographs, everything should look the same. This is a picture of what the tissues look like around a natural tooth, and this is what they look like around a dental implant. And you can see right here, you've got your gingival fibers, and if you look at how many gingival fibers you have supporting the implant, look at all these vertical gingival fibers that are supporting the tissue to the alveolar crest, and you don't have those fibers over here on the dental implant. And then on the side here, the periodontal ligament fibers are present. On an implant, there's no periodontal ligament fibers. The bone integrates or osseointegrates directly with the surface of the implant, and that's why the implant is threaded, is so that you can get more support with the bone in there. So you've got your, around your implant, you've got your junctional epithelium, which attaches to the implant surface and forms the biologic seal, similar to the way it does on a tooth. You've got your connective tissue fibers. They run parallel to or encircle the implant, but there are none that are running vertically. The periodontal ligament, you have no periodontal ligament. You have no cementum, and your alveolar bone makes direct contact with the implant surface. So in peri-implant health, similar to gingival health, you should have absence of erythema, no bleeding on probing, no swelling, and no suppuration. Clinically, it should look, the tissue around the implant should look very similar to the implant or the tissue around natural teeth. Probing depths may be deeper compared to healthy tissue due to the orientation of the connective tissue fibers. So again, you can see that the connective tissue fibers, you don't have any horizontal ones supporting that sulcular epithelium. So you've got your probing depths that can be slightly deeper, but still be healthy. So probing is not the best measurement of implant health. These are pictures of healthy implants. And if you look at the tissue around this implant here, and you look at the tissue around the supporting teeth, it looks the same. If you look at the alveolar bone, now the alveolar bone is not exactly the same, but it's at a healthy height. And if you looked at this radiograph, what you would want to do then is compare yearly radiographs to this radiograph to measure the alveolar height. This is just another picture that's considered healthy tissue. You can see it looks pretty much the same. This one's got some alveolar or some thinner bone, I guess would be the way to put it. But if you look at the radiographs, they all look healthy. Peri-implant tissue inflammation. So now we're going to talk about peri-implant diseases. Plaque deposits can form on implants. They can result in inflammation of soft tissues, and if the disease progresses, you can lose osseointegration. In other words, you can lose bone and lose the implant, just like a natural tooth. There are two forms of peri-implant diseases, peri-implant mucositis and peri-implantitis. Peri-implant mucositis is muco being mucosa, affects the gingival tissues surrounding the implant. It's also similar to peri-implant gingivitis, or gingivitis on a natural tooth would be. It affects the surrounding tissues or mucosa. Peri-implantitis affects the bone. So peri-implant mucositis, also called peri-implant gingivitis, is plaque biofilm induced. But there is no loss of supporting bone. So what you have to know when you're looking at and evaluating an implant and it says no loss of supporting bone is compared to your benchmark, because you're going to lose a little bit of alveolar bone initially, but after that initial loss, the bone level should stay the same. It is reversible, just like gingivitis. And it can progress to peri-implantitis, just like gingivitis can progress to periodontitis. It requires close monitoring of the signs of mucositis, such as the tissue redness, the swelling, the bleeding, the increased probing depths. These are some pictures. You might see that. You might see that. Peri-implantitis affects the soft and hard tissue surrounding a functional osseointegrated dental implant. Plaque biofilm-induced inflammation is present, and it's progressive with the loss of alveolar bone. You'll see signs of inflammation, bleeding and separation upon probing, and increased probing depths. So you notice that these are kind of fall in this order of importance: signs of inflammation and presence of bleeding and separation. Probing depths, not as important. Then you'll look at progressive bone loss. So there'll be progressive bone loss. It begins at the coronal portion of the implant while the apical portion continues to be osseointegrated. The implant does not become mobile until final stages of disease. So if you have a mobile implant, you have a failed implant. Vertical destruction of the crestal bone around the implant can happen as well. The bottom portion of the implant can remain osseointegrated and may be wedge-shaped defects or vertical defects. And you can see that in these images here. This bottom part is still osseointegrated. At this point, these implants probably are not mobile. And at this point, if you can arrest the disease and keep it halted, the patient can probably hang on to these implants with good home care. Peri-implantitis, and you can see here's some pictures of peri-implantitis. You can see that the alveolar bone dips down. They've lost that nice alveolar crest. So peri-implant disease etiology. So what causes it? Bacterial infection. So it's plaque biofilm bacteria induced. Or there could be some biomechanical factors contributing, such as their medical history. The patient's diabetic. The patient smokes. So those things will increase the possibility of peri-implant diseases. Mucositis is primarily plaque biofilm induced on a healthy implant, and it's a precursor to peri-implantitis, but does not always lead to peri-implantitis. So if you catch it early, you can reverse it. Patients who have implants need to be seen on a more frequent schedule for perio maintenance, or if they're not a perio patient and say they had a tooth knocked out in a car accident or a bike accident or something, and they had an implant placed, they still need to have that implant monitored more closely. Peri-implantitis is also a bacterial infection and a host response. No single organism is responsible, so there's all kinds of bacteria that can cause this, and the rate of destruction on an implant is faster than the rate of destruction on a tooth. So risk factors for implant disease: if you have previous periodontal disease, if you have poor plaque biofilm control, if you're a smoker, if you have residual cement, or biomechanical overload. Biomechanical overload means more like occlusal trauma. So the implant isn't placed exactly right, and the occlusal forces are too hard on it, or the patient's a compulsive tooth grinder or clencher and they don't have an occlusal guard, or they do and they don't wear it. This is what residual cement as a risk factor looks like. So you can see on this radiograph, there's a piece of cement that's going to cause that area to the bone to resorb there. Biomechanical overload are collective forces influenced by a number of factors, such as implant placement, the number of implants supporting the prosthesis. So if you place 2 implants and expect it to support an entire denture, you're going to have biomechanical overload. The occlusal force has to be distributed evenly among the remaining teeth. So you need to place enough implants so that the occlusal force is not too hard on any single implant. Implants lack the protective structure of periodontal ligaments. Implants are in direct contact with the bone. Forces placed on an implant are transmitted directly to the bone, so it is critical to minimize forces placed on an implant. So sometimes some doctors even will place an implant on somebody who has like what we call a hard occlusion, or they bite really hard, their teeth together. They will actually take the implant down a little bit lower than the surrounding teeth so that the surrounding teeth contact first before the food gets onto the implant and causes force, in order to keep the occlusal force lighter on an implant. Those are all decisions that are made by the doctor. Your part of this process is to recognize when an implant is having a problem. How do you know if an implant is failing? So the clinical signs in the soft tissue first. The peri-implant pocket measured with a plastic probe. Now we use plastic or metal. Bleeding, suppuration, swelling, and swelling. Pain is usually not present. If a patient's experiencing pain around an implant, it usually means a pretty significant sign, but they don't always experience pain. Changes to bone support. Mobility is the best indicator of implant failure. And so that translates to lack of osseointegration. So in other words, the joint collaboration between the implant and the bone has separated or failed. When you think of mobility, think of like a tree post or a fence post, a fence post in the ground. If you take the fence post and you rock it back and forth, you're eventually going to make the hole in the ground bigger. And it works that way with an implant. If the implant is subject to occlusal forces or bacterial overload and it becomes, the bone becomes destroyed, the implant's going to become mobile. The more mobile the implant becomes, the more likely it's going to be to continue to make that hole in the bone bigger. There should be no mobility at all on a healthy implant. You can also get parts of an implant that are loose too, like the abutment can become loose. You can fracture the abutment. They can fracture the implant themselves, but that's not real common. But the abutment being loose happens. And so the crown itself might feel like it's loose or might be loose or mobile, but the implant screw is not loose. Either way, if you detect anything like that happening, bring it right away to your doctor's attention. It's a problem that has to be addressed immediately, because remember, the destruction can happen a lot faster on an implant than a natural tooth. Vertical destruction of the crestal bone. So in other words, if you get defects, vertical defects, they're going to be a wedge shape or a saucer being round shaped. Like in other words, if you were to move the implant around like this, you're going to make a saucer shaped hole. The bottom of the portion of the implant may remain osseointegrated, so it may just be around the top. So it may be spinning like this. And the radiolucency indicates that bone loss is adjacent to the implant. So how do we treat them? One of the ways we treat implant issues is with this little tool. It's an air polisher. It's fairly new on the market. It's made by Hu-Friedy. I had one of these in my practice. It's for non-surgical periodontal instrumentation. You can use antiseptics, local systemic antibiotics. The air polisher has a glycine powder in it, which is much softer and finer than the baking soda that's in a ProfiJet, but it works similarly to a ProfiJet. You can also use Cavitron tips that are plastic coated or piezo tips that are plastic. Clinical monitoring of dental implants. Routine monitoring of implants is part of a comprehensive exam and maintenance and is essential to effective management of peri-implant disease. So we're going to collect data on an implant, just like you collect data on teeth. You're going to probe it. You're going to assess the attachment levels, assess for bleeding, assess for evidence of suppuration or pus, and you're going to collect routine radiographic evidence of health or disease. Probing. Your initial probing depths collected upon seeding of the final restoration. So right after the restoration is seeded, you should probe it.